Hello, this is the anatomy of the shoulder joint. This is the glenoid, and this is the humeral head. So this is the shoulder joint. Now the glenoid is small and the humeral head is large. So that's why the dislocation rate here is high, and this is a very unstable joint. Now this is the coracoid process. The coracoid process is a bulging from the neck of the glenoid, and it has got attachment for a very important muscles, which is the coracobrachialis and bicep brachii muscles. Now this is the lesser troch, this is the bicipital groove, and this is the greater tubercle. This is the lesser tubercle, and this is the greater tubercle. While this is the anatomical neck. This is the anatomical neck, and this is the surgical neck. While this is the acromion, and this is the clavicle. The acromion and the clavicle forms a joint which is called AC joint or acromioclavicular joint. Now this is the X-ray. This X-ray is showing the articular surface of the humerus. This is the line which is the anatomical neck. This is the surgical neck. This is the greater tubercle. This is the lesser tuberosity. Now this is the coracoid process. This is the acromion, and this is the clavicle. While this is the spine of the scapula. The muscles around the shoulders are very important. The important one are this is the view which we are looking from above. So this one is the supraspinatus muscle, this is the subscapularis muscle, and this is the infraspinatus and teres minor muscle. So if we look from the front, then we can see the subscapularis muscle here. It is in the front of it is attaching to the lesser tuberosity and in the front of the shoulder joint, and this causes internal rotation of the shoulder. While this is the suprascapularis muscle. Suprascapularis muscle passes below the acromial process, and the bicep runs in the bicipital groove. While the looking from this interior aspect, we can appreciate the coracoacromial ligament. Coracoacromial ligament attaches between the coracoid and the acromial process. And looking from the posterior, we can appreciate the muscles, which is the infraspinatus muscle, which is attaching to the greater tuberosity, and the teres minor muscle, which is also attaching to the tuberosity muscle. While the origin of the infraspinatus and the supraspinatus is also visible. The supraspinatus arises above the spine of the scapula and inserts on the head of the humerus. While in this we can also appreciate the axillary nerve. This is another slide which is showing the subscapularis muscle and the nerves which are passing medial to the coracoid process. So these are the nerves, trunks and cords which are passing to the medial to the coracobrachialis muscle. So doing any kind of surgery here, we have to be very careful going medial to the coracoid process. While this is the axillary nerve. The axillary nerve goes posteriorly, and it supplies the two muscles, the deltoid and teres minor muscle, and a small area over the skin or the lateral aspect of the shoulder joint. Here we will also talk about something about the this glenoid. The glenoid is a cartilage cartilaginous structure, which is giving stability and also increasing the surface area of the glenoid. This labrum is attached to the periphery of the articular surface, and it injured during the dislocation at this area. This is the slide which is showing the pathology in the glenoid and the labrum. This is the articular surface, while this is the labrum, which is attached with the capsule. So when the humeral head dislocate anteriorly, it most of the time injured this soft tissue area, and this is called the soft tissue Bankart lesion, and it is the most common lesion associated with the shoulder dislocations. Sometimes there is not only the soft tissue lesion, but also there is a bony lesion of the anterior-inferior surface of the labrum glenoid, and this is called bony Bankart. The dislocation of the shoulder can be classified into anterior, posterior, inferior, and habitual. The anterior dislocation occur most of the time in 95% of the patients, while the posterior dislocation occur in only 5%. While the inferior is also called luxatio erecta, and it's occur in less than 1%. While the habitual dislocation, they are the non-traumatic dislocation, and it's present as multi-directional instability, and is most of the time painless. This is the patient which present with the shoulder dislocation. Look at the contour of this shoulder as well as this shoulder. This kind of patient, when presented with acute dislocation, they have this kind of shoulder presentation and an acute pain. They are in acute pain. When the patient present with the acute dislocation of the shoulder, they should be reduced as early as possible and should be immobilized. This is the X-ray which is showing the anterior dislocation in AP view, while this is the X-ray which is showing the anterior dislocation in Y view. It's going anterior to the glenoid, while this is the axillary view. The axillary view is showing the dislocation this is the glenoid, and this is the head of the humerus. While we can also appreciate a Hill-Sachs lesion. A Hill-Sachs lesion is the indentation in the humeral head, which is caused by the glenoid. The glenoid here is indented into the humeral head, and this lesion which is produced in the humeral head is called Hill-Sachs lesion. While in this X-ray we can appreciate a small fracture from the glenoid, and this is called bony Bankart. Now this view is also called, now the another view is Y view. The Y view is the patient is standing in this position while the cassette is here. He is facing the cassette, and the beam is directed along the scapula, blade of the scapula. So the scapula will come like this. We will see this blade of scapula here. This is the coracoid process, and this is the acromion. So this we can see over here. Again, this shows the direction in which the head dislocates. If the humeral head goes in this direction, this is anterior. If the humeral head goes in this direction, it's posterior dislocation. While this X-ray is showing the Y view, and this is the blade of the scapula, this is the humeral head is lying over here. So this shows the anterior dislocation, while the humeral head is lying lateral to the scapula, and this is called the posterior dislocation. So if the humeral head goes toward the spine, this is the anterior dislocation, and if it is lateral to the goes away from the spine, this is posterior dislocation. Dislocation occur. What are the associated injuries? So in 30% of the cases, Hill-Sachs lesion occur I have already explained the Hillsec lesion, which is mostly on the posterolateral aspect of the head. While also the Bankart lesion. The Bankart lesion can be kept as soft tissue or bony. I have explained that. And glenohumeral damage can occur. The rotator cuff injury mostly occur in the elderly. The nerve injury occur and most of the time axillary nerve, which is in 20 to 50% of the time, while the artery damage is rare. So when the patient presented to us in an emergency with the dislocation of the shoulder, we have to. There are many methods for the reduction of this dislocation. We have to provide, most of the time we provide some analgesics and some kind of sedation, and we do the reduction. There are some methods which is traction, counter traction, Hippocrates method, and we will see them in the pictures. This is the traction, counter traction method. One person is holding the strap and the other is pulling the arm. This is a Hippocrates method. Here the foot is in the axilla, the foot is in the axilla while he is pulling the arm. Now there are different type of methods. This is important is Cocker method, in which there is we slightly first externally rotate and then we do adduction and then we do internal rotation. This is called Cocker method. This is important and written in the books. While in elderly, we can also do reduction by putting one hand in the axilla and giving a force in this direction, while in the other hand we can pull it down with this hand. This is the same counter reduction. Another method is the chair method, in which the patient is sit in the chair while this portion is he is facing the chair in this direction and pulling on the side of the chair the hand down. This is the stem hanging method. A weight is attached to the hand and the patient is left in this prone position. This is another method which is a self-reduction method. The patient himself is pulling the arm in this direction. Most of the time the patient has this is the labrum, and the labrum is detached from the bony surface, while this is the posterior aspect of the humerus and there is indentation. So this is Hillsec lesion and this is bony this is a Bankart, soft tissue Bankart lesion. Doing after acute dislocation and after reduction, the patient is given a sling for 2 to 3 weeks, and then we can examine the patient for the instability, and we can do MRI. We can appreciate this defect in the MRI, and we can also calculate this defect on MRI. So the lesion, the treatment for this lesion is sutures. The repair of the Bankart lesion. This Bankart lesion is again sutured back to the glenoid labrum. The labrum is attached again. So this is called Bankart repair. This can be done arthroscopic as well as open. This is another slide which is presenting this is the glenoid, and this is the humeral head. So this is a suture anchor, and it is again for the repair of the glenoid, of the labrum to the glenoid, while this is another which is demonstrating the remplissage procedure. We pull a suture, anchor suture, and then we tight it with the capsule. This is the MRI, which is to calculate the area of the lesion of the Hillsec lesion. The Bankart lesion and the remplissage lesion procedure, the Bankart procedure and the remplissage procedure.